Good afternoon. I know I'm the one standing between you all lunch and the scientific extravaganza. So I'll be very miser and I'll have an Ayushman-like presentation. I'll just have 5 slides. Thank you, Kamal Bhai, for having me here. Uh, so this is the patient. I just want to draw your attention to a few points. He's 47-year-old. He's very young. He has very recent 2-day-old, probably ST elevation MI. His troponins and his anti-proBNP is very high. Troponin is more than 50,000, anti-proBNP is more than 2,000. He is in heart failure with reduced ejection fraction, which is somewhere around 15 to 20% at present. His ventricle is dilated. Uh, he's got an MRI done within 2 days, and that shows that his anterior wall is akinetic, burnt out. Also, there is severe MR, probably due to angular dilatation of the lateral wall ischemia that he has. His lateral and inferior walls are badly ischemic, both circumflex and right side have 90% lesions. So the questions are should we wait for surgery? Yes, at present we wait. This is a very angry heart. It's going to be very irritable. It's suffered major insult 2 days prior. The outcomes are going to be significantly bad if we operate, especially with an ST elevation MI. His heart has recovered a bit in last 2 days, as evidenced by the improving creatinine, improving symptoms, improving blood pressure, and him getting better. So we will wait. We will optimize him. We will. As mentioned, he's already on all 8 medicines. But if we are really not happy with the recovery as yet, there are other tools. There is IBP with us. We will give him a few weeks probably to settle down. We'll keep reassessing him. We'll have a very tight and very strong follow-up with him. Reassessing the ejection fraction and MR once the event and the heart has stabilized will give us better assessment and idea if at all we are going to take him to the OT and what exactly we are going to be faced with. And also this cooling off period is going to give time for other organs to recover. His lungs are going to get drier, his kidney is going to get better, and that is going to help us with the surgery and post-operative. If we decide to operate, which I think we should later on, should we leave behind MR? This heart has already dilated. His LV IDD is somewhere around 65, if I remember. If you leave behind this MR and only do CABG, the post-operative period usually is very stormy. They require very high inotropes. They go into the failure. They don't come off ventilator so easily. These patients tend to behave relatively better if the mitral valve pathology is addressed and especially if it is repaired. Repairing a mitral valve, adding cardiopulmonary bypass, and repairing this mitral valve is really straight going. It's a very straightforward surgery for people who are doing it regularly. Fixing ischemic mitral regurgitation, either with a repair or in a very rare case with a replacement, is a straightforward cardiac surgery along with the CABG. If at all he needs, sorry, no amount of drugs or revascularization alone is going to fix the displaced capillary muscles or the dilated annulus, which must have happened with the dilated ventricle. And even if you need IBP post-operatively, it will be relatively easy to manage with the MR fixed. So I guess we wait, we give him time to cool off. We do take him for surgery later once the patient and everybody else, including the surgeon, is happy, and we fix the MR one way or the other. Thank you.
We invite Dr. Manik Chopra for his presentation. Dr. Priyank, you can join here with us. So new modality, how do we do T? This is the next up thing in interventional cardiology.
Good afternoon, and thanks all for this opportunity. Okay. Yeah, so this basically is about ischemic MR and MT, and these are my disclosures. And uh, the main criteria, the main question which was there was what are the echo criteria for patient selection for H2H repair therapy. And we know that there are two subsets of mitral regurgitation. One is secondary mitral regurgitation, in which it's primarily not the disease of the leaflets and the mitral valve complex. And in these scenarios, I mean, for sure, if the patient has a LV ejection fraction which is on a lower side, less than 50%, you have optimized the patient medically. And then if the ejection fraction is in between 20 to 50, their LV systolic dimensions are less than 70 or preferably less than 55, I would say, and PA pressures less than 70, then these patients would benefit from tricuspid H2H mitral valve repair. We need to understand that we need to intervene into a sweet window in which the ejection fraction is not very low, not a completely burned out sort of LV, which is less than 20%. Also, in which the LV is completely dilated, because these are the patients who might not do very well after this therapy. So the patient selection has to be good. And I would come later to the patient mitral valve anatomy favorable, meaning that what all other things which we are going to see. These are certain supporting things, but I would skip them. And then you have primary mitral regurgitation, again, in which the criteria would be similar. Mainly, it is for the patient in which the surgery is being denied or the surgery is very high risk, and the patient falls into these criteria again. Regarding the mitral valve anatomy, we need to understand that the initial cases were in between the A2 P2 segment. We all started with the A2 P2 segment, and the main idea was to flip that and to accept whatever degree of reduction of mitral regurgitation happens. Over a period of time, we started going into commercial areas also, even P1 and A3, P3 also. Other things which we need to see is that your baseline mitral valve anatomy, the gradient should be less than 4, so that once you put a clip, you don't create a stenotic problem. Also, you need to measure the mitral valve area as you do for PNV to understand it's more than 4 centimeters square. Also, to assess the leaflet in a similar manner, the same thickness, mobility, calcification, subvalvular apparatus, just to understand that the leaflets are pliable enough, the area where you are going to catch the leaflets are non-calcified, and the PML length, so that you have enough length to catch the PML, because the PML is the one which gets tethered and restricted more. So this is regarding the patient selection part, and then the second thing was whether you should try this therapy for ischemic mitral regurgitation. Now, broadly speaking, it would be three subsets, I would say. One is papillary muscle rupture or cord rupture. We know that which happens with acute coronary syndrome. This setting is not a very great setting. The second is the association with the ACS without any apparent papillary muscle problem or caudal damage. And the third is over a period of time when it is called as chronic ischemic MR. Now, to understand how does this MR happens, it's mainly related to the tethering of the valve leaflets rather than annular dilatation. There are two forces. One is the tethering force, which is applied by the papillary muscles and the chordae, and the second is the closing force. And this balance keeps mitral valve, in place. So in first situation, we know that your papillary muscle has ruptured, and there is no tethering force. So that leads to severe MR. In the second situation, in which there is ACS without any apparent papillary muscle damage or cord rupture, it's basically decreased contractility of the LV, leading to the decreased closing force. At the same time, the tethering force remains same, which leads to MR. And the third situation, which is chronic ischemic MR, which is basically due to LV remodeling, which leads to papillary muscle displacement, leaflet tethering, leading to incomplete coaptation, and thereby leading to MR. There is a contribution of annular dilatation to this also, but the tethering component is more. also reduce closing forces. But again, these two, annular dilatation and closing forces, are something which doesn't contribute that much. Now, coming to what would be the way to treat these patients, I would say it would be almost always heartbeat discussion, depending upon which situation we are in again. Papillary muscle rupture and bone rupture, typically we know that the patient is going to be very sick and has a very high surgical mortality, but that's the only way to go forward till now. There are cases in which clip therapy has been offered when the surgical risk is prohibitive and it becomes sort of a let's try this sort of situation. But we need to understand that at this moment of time, all of us are probably into this therapy, and we are not reached to a stage that probably we should be trying these cases unless and until they are being surgically denied. Second is associated with ACS without papillary muscle damage and cord rupture. For sure, we should try to fix the cord. If the patient is very unstable in a STEMI situation, fix the coronary arteries and then wait for the mitral regurgitation to recover, which typically happens in 50% of cases. However, if it doesn't happen, we will try to stabilize the patient medically. If it doesn't stabilize, again the same thing, we can consult the surgeon first because that is the traditional thing which we are going to do. Many times in non-STEMI situation, you don't fix everything. There would be something which is residual. Again, you should take an opinion of surgeon. If they say it's high risk, this is one subset in which you should try to jump. But the idea is to delay as much as possible, so to buy time, so things to stabilize. And chronic ischemic MR, again, traditionally, this subset was by the surgeons, but we know that many times when there is an infarcted LAD and it's a global hypokinesia sort of thing, in those patients in which the coronary arteries are not very important to fix, I would probably consider giving an option of ear therapy to the patient. Coming to this particular patient per se, this again is a stabilized patient. I would like to push the patient as much as on medical therapy as much possible to buy time so that the patient becomes more and more stable, either for surgery or for TIA therapy in coming days. And if it is anatomy is suitable, I may offer it as an alternative to TIA therapy, making them understand that if the coronary artery disease are critical, we need to fix them up later on, either by a simple thing, or if it is complex, it might require some sort of support to fix them. Also, to make them understand that surgery is sort of a gold standard in this situation, and also to understand that if this therapy is sort of a bridge to a cardiac transplant in your situation because the EF is anyway going down. Also, we need to understand the financial and logistic part of all these things. And regarding the last question is regarding the Indian scenario for NPF therapy, we know that we have three companies. The first one which entered was Microclip, and this is how it looks like. You can see the clip on the top and the delivery system and catheters behind. The next in line was democratization of therapy by Merrill Life Sciences, which is an Indian company which came up with a clip called MyClip. And in coming days, we would see Edwards coming up with therapy called Pascal in India in the next year. Thank you.
And now for the last topic of the session, whether heart transplant would be a reasonable option with or without LVAD in such a patient. We have Dr. Chirag Doshi. I think replacing Dr. Chirag Doshi is Dr. Ashish. Welcome, Dr. Ashish.
Good afternoon, everyone. Due to some emergent work, Dr. Chirag Doshi is not able to make this meeting, so I'll be making his presentation. So, coming to the session of questions, the next question that we'll be answering is, can ASCVD be a determinant of eligibility of heart transplant? To answer this question, let's have a look at the AATS consensus document to deal with patients of CAD with severe LVD. Here, the first thing that we need to do is we should be sure with the diagnosis and the intensity of severity. Once we have done this, next thing we should look at is what are the high risk factors these patients are having. So, if they have an extended form of heart failure, like patient with higher class of NYHA or on inotropes, or if the coronary artery disease is very bad, like very severely diseased coronary arteries or dilated LV, with LV aneurysm or non-viable myocardium, or when there is extensive amount of adverse remodeling, like severe form of mitral regurgitation or tricuspid regurgitation or RV dysfunction. All these characteristics will put these patients into a high-risk category of CAD with LVD. So these patients needs a special form of treatment, and they should be seen by heart failure team. And these would probably be our next heart transplant candidates. So once these patients are identified, we need to then have a multidisciplinary approach for these patients. And they have to be properly evaluated to answer one question, whether these patients are candidate for revascularization. And if they are not candidate for revascularization, then they should be followed on heart failure management track. And these patients remain stable with medical management and device therapy for a long time. And we don't know when they will need for the next level of treatment. And this simple algorithm, like I need help, helps us to identify these patients early. So any patient who need inotropes, whose NYT class is worsening, whose end organ disease is worsening, low ejection fraction, life-threatening arrhythmias, or recurrent hospital admissions for heart failure, all these patients have to be picked up early and should be referred for a transplant as early as possible to have better results, provided that they don't have contraindications. So we need to evaluate these patients for contraindications as well. So if any patient has got high pulmonary vascular resistance or a high PA pressure or high transpulmonary gradient or an end organ dysfunction, malignancy, or systemic disease which is decreasing his life expectancy, then probably transplant might be not a good option for them, and they would be better on medical management or newer device therapies like a durable LVAD as destination therapy. So coming back to our scenario, we have a patient who's already in advanced heart failure situation, who has a recent evidence of decompensation, who's been recovering from it and was on inotropic support. He's already having a non-viable myocardium and has a severe MR as a marker of adverse remodeling. So in these patients, probably it is an easy decision to consider him to be evaluated by a heart failure team and look in terms of heart transplant as a better option for him. The only caveat here is that his end organ dysfunction, form of renal dysfunction, the serum creatinine, the EGFR is on just on the fence. It is on 30. So here we have to be careful. We need to optimize further for this patient and see if this EGFR remains stable or improve, and then he becomes a low-risk candidate for isolated heart transplant. However, if EGFR drops or it doesn't improve, then he might be better to be managed by or bridged by a ventricular assist device to improve his cardiac output and improve the cardiorenal problems to get a better outcomes. So the next question, how do mitral repair plus CABG fare against transplant? Now, if we see ICMP as a pack, it comes as a package. It is not a one problem. Like normally these patients have valvular regurgitation, they have severe forms of LV dysfunction with aneurysm, poor vessel quality. So it adds to surgical problems, and we need to be adding more procedures. Similarly, pre-op patients are sick, so we might have to optimize them in pre-operative and need more kind of difficult situations in post-operative stabilization. So this is like repairing an old house versus building a new house. So in that situation, if we can address the whole problem as one solution by transplant, I think that offers better situation in this kind of problems. So we need to have these three questions answered. What is the extent of heart failure? How severe is the coronary artery disease? And is the myocardium viable? If it's a non-viable myocardium, it's like watering a dead plant. So we might not get good results with extensive and multiple procedures. Transplant might be a good solution in this case. And it definitely provides a more complete restoration of cardiac function, better quality of life, and superior long-term survival as compared to CABG with multiple procedures, as we can see in the table. And only thing is, it is not as good as it sounds here. Sometimes we have problems because of long-standing immunosuppressions, limited availability of donors, and limited availability of facilities of these services and cost, of course. The third question to answer immunosuppression scenario in India, I'll skip this. These are the common problems which are universal with immunosuppression, like infection, malignancies, renal problems, bone problems and hematological problems. But in Indian scenario, we are facing more communicable disease problems. So in immunosuppressed patient, this becomes a major issue in perioperative and postoperative period. Financial constraint, non-compliance of drugs, because these drugs have to be taken regularly. People just find that they are good and they stop taking these medicines, and then they present with very late form of problems to us. Suboptimal monitoring, like we know that many of these drugs, their titers have to be monitored. So lack of facility or financial issues sometimes prevent proper monitoring and can cause problems in later postoperative period. Many of the patients present to us very late with problems. They just ignore infection, ignore symptoms of rejections, and then they come with very late stage where we can hardly do anything to them. And the late presentation of patients for transplantation is a major problem, so that they already have a high disease burden, which can increase mortality and morbidity in perioperative period. So to improve this, we need to improve patient education, improve financial support, early referral for transplant, and increase use of telemedicine and penetration of such services in rural area might help us to overcome this problem. Thank you very much.